So my name is James Fitzer. I'm the director of Access Accelerated. And on behalf of my member companies and partners, it's really an honor for me to welcome you here this evening. We really appreciate you taking the time out of your very busy schedule during what is a very busy week to come and spend some time with us today.
Is that what you think we have to do?
We hope that we have organized a very interesting series of discussions around multi-sectoral collaboration for UHC. So Access Accelerated is committed to taking steps to reduce barriers to prevention, treatment, and care for non-communicable diseases in developing countries. We ensure that we work to contribute directly to national identified priorities and then bring the people that are living with NCDs into the center of everything that we do. While we're making progress, we have a broad scope of technical capacities from our member companies and our partners. We understand that there's a lot more that we can do. But we also recognize that we need to work together, that multi-sectoral collaboration is the way forward, and that we need to see how to do more and how to do better. Access Accelerated is at a very exciting point. We're building on our lessons learned from the first 3 years of our implementation and moving into phase 2, and where we hope that we can actually push further, find different collaborating partners to really work to build the capacities to help address the people that are living with NCDs. Tonight, I'm delighted to welcome, as I look through the room, I see many distinguished guests. But as this is the 3rd annual event that Access Accelerated hosts on the margins of the UN General Assembly, I'm delighted to see that a lot of friends and colleagues that we have met and collaborated with over the past few years. So thank you so much for being here. We hope that tonight we can build on the very important discussions around the high-level meeting for UHC and make a contribution to keep the energy moving and help us all to move from words to action. So with that, I look to my friend and colleague, Dr. Dennis Laya, who is our first keynote speaker. So Dennis, will you come up and join us?
Thank you very much, James, and thank you for the opportunity. Distinguished ladies and gentlemen, I'm delighted to give this short keynote address at this meeting, which is aimed at exploring the future of public-private partnerships for NCDs, particularly in this age of UHC. A few years back, NCDs were considered insignificant public health issues in the part of the world where I come from, largely because infectious diseases predominated. How times have changed. NCDs are on the mouths of all, and sometimes I'm amazed at how much NCDs are spoken of. But I ask the question, has action on NCDs gone beyond mere talk? I have no doubt that if I should ask you in the audience now, I'm going to get varied responses to this question, on whether we've moved beyond talking about it into real actions. At a recent meeting in Denmark, I think it was last year, on NCD financing, I remember vividly the call for us to walk the talk by channeling resources into NCD prevention and control. And I believe that this meeting offers us yet another opportunity to explore issues relating to financing for NCDs, in this case, public-private partnership. I recently came up with a definition for NCDs, and I want to crave your indulgence to listen to this definition I came up with NCDs based on my experience as a clinician and also as a program manager for non-communicable diseases in Ghana. So I consider NCDs as a complex set of disease conditions associated with multiple risk factors, sometimes with ambiguous pathways of causation, difficult screening and or diagnostic methods, and often complicated methods of treatment, with extreme variations in clinical outcomes. As long and complicated as my definition sounds, the reality for NCDs, as far as I'm concerned, is what the definition is putting across. The very complicated nature of NCDs means that conventional practices which we have employed for infectious diseases do not necessarily or may not necessarily work for NCDs. This means that we need to look for innovative ways to deal with the NCD problem, and exploring public-private partnership, I believe, is one of the options. So permit me to briefly contextualize public-private partnership and especially universal health coverage using Ghana. In 2013, Ghana launched an NCD policy and a strategic plan. And during the period of implementation, we achieved several key things, amongst which included the establishment of a multi-sectoral steering committee to oversee non-communicable disease prevention and control in Ghana. Others include the inclusion of non-communicable diseases in the benefits package of our National Health Insurance Scheme. And this is particularly important when we look at the advent of United Nations Sustainable Development Goals, which seeks to achieve UHC as amongst one of the key objectives for health. The question remains, can government alone achieve UHC, which includes coverage for non-communicable diseases, and especially in developing countries? I doubt if this is feasible. Ghana's quest to achieve UHC is driven by the desire to ride on our existing primary care services, which is christened the community-based health planning and services. Our working definition for UHC is that all people in Ghana have timely access to quality health services, irrespective of their ability to pay at the point of use. The Ministry of Health is actively pursuing this, and the package of interventions will include 7 key thematic areas. So preventive, promotive, curative, palliative, rehabilitative, and mental health and emergency services singled out for consideration. On the involvement of private sector, Ghana has explored public-private partnerships in the health system with some success. So for example, some health facilities have employed banks to be mobilizing revenue for them in their facilities, ensuring that revenue leakage was brought down. This is an example of private sector involvement in healthcare delivery. There are others, such as the outsourcing of services in the area of security, catering, and others for the private sector. Specifically for NCDs, I'll give a few examples. So for example, we have 3 radiotherapy service centers in the country, and one of them is privately owned. Another example of private sector involvement in the NCD space is the provision of health service by private health facilities under the National Health Insurance Scheme. This means that we're improving access or increasing access to health care by the establishment of private health facilities, which then get reimbursed by the National Health Insurance Scheme. The private sector has also been involved in the training of human resource for health. So for example, in the training of oncologists and oncology nursing, we have some pharma companies supporting this. And this is an example of private sector involvement in health service delivery for NCDs. Beyond service delivery and training, the potential for the private sector to be further involved in NCD prevention and control has been recognized in our current revision of Ghana's NCD policy, which is in the final stages. The policy revision process took cognizance of the fact that private sector has a key role to play in achieving the objectives, including reducing the burden of NCDs in Ghana. Among the proposed strategies are continuous engagement of private health facilities, corporate organizations, and corporate groupings, such as the Private Enterprise Foundation in Ghana and the Ghana Club 100, to explore investments in NCD prevention and control. Private sector involvement in NCD prevention and control will have to move beyond just corporate social responsibility and must be driven by clearly articulated plans to improve staff health, for example, through the implementation of workplace strategies to prevent NCDs. The recognition of the need to invest in the prevention of NCDs with the potential for positive impact on productivity and financial benefits to institutions are among plans proposed to ensure active private sector engagement in the NCD prevention and control efforts in Ghana. UHC for NCD also means access to diagnostics, access to medicines, and other services. It also means availability of screening programs to identify the high proportion of persons with undiagnosed NCDs and the linkage of such persons to care. Multi-sectoral collaboration is another critical component of the NCD prevention and control spectrum. Government, civil society, academia, and other sectors have critical roles to play towards achieving the common objective for NCD prevention and control. Clarity on roles and responsibilities of all actors is important. Collaboration rather than competition. The need for the various actors to recognize themselves as allies rather than antagonists or competitors are sure to guarantee some success in our quest to reduce the burden of NCDs. Although multi-sectoral committees have been recognized as important requirements in ensuring success in the implementation of NCD prevention and control activities, the mere establishment of a multi-sectoral steering committee doesn't guarantee success, even though its absence would most likely spell doom for cross-sector collaboration, which is important for NCD prevention and control. In our draft policy and strategic plan, the technical working group responsible for the drafting brought together stakeholders from all identifiable aspects, including the media, academia and research, private sector, civil society, security services, tax and internal revenue agencies, education, law, international organizations, just to mention a few. And we had to agree on the roles and responsibilities in the implementation of the proposed policy and strategic plan. Ghana hopes to strengthen the multi-sectoral steering committee to continuously engage actors to achieve success. Distinguished ladies and gentlemen, I wish to humbly add my voice to the call to action on NCDs in line with SDG Goals 3.4, which seeks to reduce premature mortality from NCDs, and Goal 3.8, which seeks to achieve universal health coverage. The private sector can play a critical role in achieving these goals. NCDs present one of the biggest challenges to achieving UHC, particularly in developing countries. Our efforts at cross-sector collaboration, including the involvement of private sector, will determine the extent to which we achieve success for UHC. Active efforts at engaging private sector are sure to yield good results if these are pursued in the spirit of collaboration and mutual benefit. And I strongly encourage this. I thank you very much for your attention.
Well done.
Thank you so much, Dennis. I think that it's so important for us to hear directly from you what your priorities and challenges are so that we can come together to see how to add sustainable support. We really appreciate you being here with us today. Thank you. So now I'm very happy to shift gears and we will hear from the World Health Organization. It's my pleasure to introduce to you Dr. Svetlana Axelrod, the Director of the Global Coordination Mechanism for the World Health Organization. Dr. Axelrod, thank you.
Good evening, distinguished guests and dear colleagues and excellencies, and really it's a great pleasure for me to be here. So I would like to take this moment and to thank you, the organizers, for this very important event which is going and very aligned with the theme of the UN General Assembly that we have now and the high level meeting that we have in New York, universal health coverage, moving together to build a healthier world. And it is truly a pleasure for me to be here among the colleagues and to see the different sectors from the civil society, from the government, and from the industry in this room, and to share our common vision, how we should go ahead and how we should achieve the work on the NCDs. And we know that we have the collective responsibility to scale up efforts in order to accelerate actions toward to prevent and control non-communicable diseases, and both at global and country level to ensure we reach the NCD target 3.4 by 2030. And today at this event, we are given another opportunity to re-enter these commitments. The UN General Assembly high-level meeting brought the head of states and the government at the global health community to New York to focus on the universal health coverage, with a view of encouraging coherent and coordinated action across the sectors and stakeholders. And really, it's a great pleasure for me to be with you today. And I want to underline the one very important issue, that this is especially critical for managing chronic diseases, since the access to the medicines and vaccines to prevent and treat the NCDs is acceptably low in many less and development countries. UHC target 3.4 will not be achieved without progress on addressing the barriers to the availability, affordability of NCD medicine. Sustainable advances have been made in global access, access to very closely medicines such as antiretrovirus drugs for HIV. But in terms of improvement access to answer these medicines, large disparities between high and low income countries continue to persist. Reliance on direct out-of-pocket payments for conditions needed daily treatment is a real economic burden for individuals and families, and poor households may close to figure treatment to to save costs. As a result, the complicated, undertreated conditions may entail even higher costs on health systems and society as a whole. What do countries need to do to improve access to essential medicines and to ensure we are on track on implementing interventions that could help achieve SDG target 3.4? A high number of premature deaths means that our member states in low and middle income countries are falling short of implementing the commitments articulated in the WHO resolutions, political declarations, and outcome documents of the high-level meetings on NCDs and UHC. To make things more complex, implementation challenges are and even in countries, there are also significant regional differences. For example, WHO Europe region is aiming higher than the other than a 1/3 reduction of NCD mortality by 2030. Others are lagging behind. Political commitments and actions are important to bring together the global community to address common threats. We have learned valuable lessons in this regard from the HIV community, especially in terms of the multi-sectoral and multi-stakeholders approach to address global health challenges. However, we have been less successful at the implementation of the high-level commitment to realize the whole of government, whole of society, and health in policies approaches to scale up actions against NCDs. The challenge is that the ministers of health alone can't achieve this. We need action at the highest level of government for policy coherence. We need ministers of finance on board to ensure proper investments. We need also ministers of agriculture, education, sport, and tourism at the whole of government, as we need to act at the social determinants as well to tackle the NCDs. Many countries have limited resources, and they need to prioritize their needs as best as they can. Others don't have the experience or conducive environments to meaningfully engage with the private sector. The good news is that the national governments are increasingly open to work with the private sector for political, economic, and health goals. But there are some concerns about the potential conflict of interest, as well as about weak regulatory system. The demand from the member states is to raise for the WHO to provide technical assistance on appropriate forms of engagement with the private sector. And we are doing our best to meet this demand. WHO General Program of Work, the GPW 13, and its triple balance targets are well aligned with the 2030 Sustainable Development Agenda. WHO estimates that the world will need to meet the GPW 13 UHC 1 billion goal by 2023 to reach SDG target 3.8 for UHC by 2030. GPW 13 also stresses the need for multi-sectoral and multi-stakeholders action. To deliver on the triple billion, WHO has introduced corresponding divisions as a part of the transformation process. WHO has also developed a number of reports that support the implementation of the 2030 Agenda and GPW 13. And I would like to highlight the two recent launches of the report. One is the Global Action Plan for Healthy Lives and Well-being for All, and the second one is Primarily Healthcare on the Road for UHC. And now I would like to say a few words about the department that I am leading, which is also a new additional as a result of the WHO transformation. Our department includes two units, the Global Coordination Mechanism and the UN Interagency Task Force for the NCD Prevention and Control. And it is placed under the Deputy Director General. The aim of the new department is to act as a catalyst to facilitate relevant cross-functional NCD-related work as a horizontally and also vertically. And the new department is particularly well situated to serve WHO, important entry point for the private sector, on NCDs with the framework of the engagement of non-state actors. And both of these units, the Global Coordination Mechanism and the UN Interagency Task Force, engage with the private sector, particularly with the business associations, through the variety of the platforms, such as the global dialogues, working groups, strategic roundtables. And the new department also leads a number of strategic initiatives to accelerate actions across sectors and stakeholders and give rise to partnerships for the global public goods. For example, the High-Level Commission on NCDs has just completed a second phase of the work, and the commissioners included 3 working groups, which one is the first one is the engagement with the private sector, the second one is the enhancing health literacy and guidelines on the establishment of national multi-sectoral coordination mechanisms, and the third one is development recommendations how to engage on NCDs and mental health into the UHC packages. I am also honored to be one of the co-chair of the second civil society working group, together with the NCD Alliance. And the working group was also focusing on the high-level advocacy in the leading up to the UNJ high-level meeting on UHC. Taking this opportunity, I would like also to announce that we are working hardly on the preparation for the global meeting on NCDs and mental health, which will be hosted by the government of the Sultanate of Oman from the 9th to 12th of December in this year. And the meeting will be including a global multi-stakeholder partnership forum. I would like to also to conclude by saying that collaborative partnerships and harmonization and alignment of the private and public goals will help us achieve SDG target 3.8 on UHC and SDG 3.4. We need to engage with the industry and to encourage the private sector to work with the government and other stakeholders on the implementation of the commitments emerging from high-level political commitments. The collaboration should be proactive, and we would like very much to hear your ideas about how we can better work together to strengthen national commitments and enhance implementation, how we can pull together public and private sector resources to improve the affordable and access to medicines and technologies for NCDs. And I would like at the end of my speech to thank you all for this attention, and we are looking forward for listening from the panel, the discussion, how we should follow on. Thank you once again for this opportunity to have a speech here.
Thank you very much, Dr. Axelrod, for being here with us. I think that you've shared with us a very helpful and practical landscape upon which now we can shift to have our panel discussion where we will discuss in more detail how to build and expand multi-sectoral collaborations for universal health coverage. I'd like to invite now our co-moderators, Caroline Rohn and Katie Dane, to join me on the stage.
We're ready. Okay, just to introduce ourselves, my name's Katie Dane. I'm the CEO of the NCD Alliance.
And I'm Caroline Rohn, and I oversee global health and serve as president of the Pfizer Foundation. Can you, not good? Is that better? Hold it up? Okay. So global health for Pfizer and president of the Pfizer Foundation, and we're really thrilled you joined us.
So thank you for choosing this event out of the 360 that are happening. 360.
We might need to share this, Katie.
Is it okay now?
Yeah.
Okay. out of the 360 events that are happening this week. So as has been described, we're really going to be focusing on public-private partnerships for NCDs and for universal health coverage. And as we all know, yesterday, a few blocks away, our world leaders, esteemed political leaders, committed to a political declaration on universal health coverage. And no doubt in this room, many of us have our own gripes about what was missed out, what was a missed opportunity, what were the great strengths. But actually, when you take a step back and you really recognize that all governments of the world essentially have committed to the principle of health for all, it is indeed a really major milestone. So for me, in terms of yesterday, I took away 3 dominant themes that we're going to pick up this evening. First and foremost, yesterday we heard many, many statements from our esteemed leaders. Actually, from the Twitter sphere that I have seen, apparently 40 of them had a specific mention of non-communicable diseases. So my first takeaway is NCDs is being recognized as a big priority for UHC. The second one, which we heard time and time again in the statements and in the negotiations and discussions, was that the real foundations of universal health coverage has to be primary healthcare. And then the third, which comes out loud and clear, I think, is the need for partnerships. We all say time and time again that governments have to be steering the ship in terms of universal health coverage, but we all know that they can't do it alone. And so this is where we're really going to pick up the conversation with our panel this evening. And what we really want to focus on are what are some of the lessons learned that we've seen to date in terms of public-private partnerships for NCDs, particularly NCD care. Secondly, what do good partnerships concretely look like? We always throw around these statements about public-private partnerships, but what do they concretely look like? Thirdly, for me and the NCD Alliance particularly, how do we ensure that people and public health outcomes are at the centre of what we're trying to do in terms of partnerships? And then really, what are the metrics for success? Do we as a community have that clear in our minds? So these are some of the themes that we're going to be trying to get out of our fantastic set of panelists, and I'll hand over to Caroline.
Sure. So I will hold this up and let me know if you have trouble hearing me. But I should say we have put this together as a panel just to know what you'll get over the next hour or so. We're going to welcome our panelists up, have some time for a dynamic discussion. And I think as Katie said, what we really want to emphasize is the reality on the ground of how you marry big policy ideas and big commitments, and then how that happens to affect both patients and communities on the ground. And then we'll open it up for some questions, and then hope you will stay around and enjoy some refreshments with all of us. Pfizer is one of many companies, as you know, that's a proud member of Access Accelerated, and I'm really thrilled to welcome up other company participants in Access Accelerated, but even more importantly, our partners. So if all of our panelists could come up on the stage, that'd be great.
This thing was a... Ladies first.
No. There's no order. You can...
There's no order?
I'll see clear.
Thank you. It's okay.
There's no order, right?
All settled? Okay. So Katie and I are not the stars, you're the stars. So if I could ask each of you just to take a few minutes, introduce yourself, your organization, and how you're working with Access Accelerated. And we'll start with you.
I need to hold it up,
Yeah.
like you. Yes, can you? Yeah, it's clear. So good evening, distinguished guests and colleagues. My name is Hian. I'm a program director for NCD. I'm working at PART. I'm number 3, please.
Let's try the mic, and then that'll help, I think. Yeah, you can hold it.
Good morning, distinguished guests and dear colleagues. My name is Hian. I'm working at PART in Vietnam country office. It's my privilege to be here today to share with you some like practical work that we have been done in the countries. So basically, we start the NCD programs since the 2016 with the support from the Novartis Foundation. We have some Novartis college here, so thank you very much for support us since several years. So for that programs, we work in the we conduct a very comprehensive intervention that can have the the people living with NCD from the prevention, early detection, and then referral, treatment, and manage the people living with NCD in the communities. And we are very proud to be the pioneer of the country to think outside the box, to involve many sectors in the programs. We will try to engage the social enterprises, private sectors, and also like community health volunteer in that programs. And we are now working with Access Accelerated with James here and other colleagues. So we work together to support the Ministry of Health Vietnam to like scale up the successful approaches and also do more broader and more coordinated action that can have the people living with NCD have a better lives, and that is we can coordinate better for the investment from the different partners. So that's a very quick introduction from me.
Thank you. Great. Carmen?
Sure. You want me to use this? Okay. I'm Carmen Villar. I'm the Vice President for Social Business Innovation at Merck, or as we're known outside of the US and Canada, MSD. I want to say thanks to the organizers, Access Accelerated, and all the partners that are here tonight participating in this event. I think it really does say something in terms of the 360 other events that are going on and that you're here after hours, so thank you. When people talk to me or meet me, they say, what is social business innovation? And the way I like to describe it is to really say that we're looking at how we can bring our responsible behavior into the future, how we can innovate and take this forward beyond just philanthropy. And I think that's what a lot of us are here to talk about tonight. So I look forward to the discussion and to your questions.
Good evening, everybody. My name is Tony Kimata. I come from Kenya, and I'm a member of NCD Alliance Kenya. And want to thank Access Accelerated for this invitation. And for me, I'll be sharing with you my journey and my experience as a person living with NCD, that being type 1 diabetes. And I'm looking forward for the engagement on the agenda that we have tonight.
Good evening, ladies and gentlemen. I'm Pangisilem Charlie. I'm the director of the Bristol Myers Squibb Foundation, working out of South Africa. I have responsibilities in that continent as well as responsibilities in China and some programs in India. I will be sharing the experiences that we had from HIV and how we have moved and tried to leverage all the investments and the learnings that we had from HIV and transition into addressing some of the issues affecting people living with NCDs. Also, I would like to thank the organizers for the opportunity, and I would like to thank my colleagues that actually are responsible for Access, who are here, for inviting me. Thank you.
Thank you very much. So it's me again, that is live from the Ghana Health Service. I work as the program manager for non-communicable diseases, and in our relationship with Access Accelerated, indirect relationship maybe, we're working with World Bank, the City Cancer Challenge path, and also the NCD Alliance Ghana on various activities in the area of NCD prevention. Thank you.
So Tony, I'm going to put you on the hot seat and start with you, and ask you, especially as an advocate and a person living with a non-communicable disease, to help us sort of think through how we can, first of all, why it's so important to integrate universal healthcare coverage and ensuring that NCDs is properly placed as countries take this on. And then from your perspective, how can we do a better job of getting that voice of advocates and of patients into the actual implementation from a policy and planning perspective?
Thank you for your question, Carol. And first, I will take you through my journey. 20 years ago, I was diagnosed with type 1 diabetes. There were so many challenges back then in my country. And in getting to understand how a person with NCD could maneuver through the health system at that time was not easy. It was not really reliable on giving that, and was really reliable in making sure you get the right advice and the right information on my condition. And UHC needs to urgently meet these needs for people living with NCDs, simply because of the impact that it's really taking on, and it's coming out. And it's not just diabetes alone. There are many communicable diseases out there. And in our country, we have had a few incidents where now it has hit on leaders and people who are decision makers in our country. And they've seen that this is not something that just is a disease for the less fortunate and so have you, or a certain class of people. NCDs affects or infects everyone, be it creed, race, gender, and everyone as a whole. And how we could, say, improve the awareness of NCDs in relation to what UHC is in our country. First of all, I would say we'd have to introduce or maybe involve the people living with NCDs. Their voices do matter. They're the ones who have the experience. And yes, maybe doctors have the knowledge, but in collaboration of those two, us as people living with NCDs, our voices do matter. And basically, we have to involve people living with NCDs.
Great, thanks, Tony. Let me come to Dennis at the end. So we just heard from Tony of the importance of putting people first, essentially, in terms of public-private partnerships for NCDs. You mentioned earlier in your keynote some of the examples of public-private partnerships in Ghana. Could you give us a little bit more in terms of how Ghana approaches and collaborates with different sectors around NCDs, whether it's to do with the strategy or the UHC response? And I guess there's two specific pieces I'd like you to kind of pull out. One is public-private partnerships have inherent uneven power dynamics within them. How do you ensure that the government remains central and in the driving seat of public-private partnerships? And then secondly, picking up on Tony's point, how do you ensure that these partnerships really reach the most vulnerable communities in your setting?
Thank you very much. I think Tony's point is very critical, involving persons living with NCDs. And one of the things we did during the process of revising our NCD policy was actually to engage the NCD Alliance, which is an umbrella body which includes persons living with NCDs in Ghana. Because as he mentioned, they have to be at the center of decision making and also be engaged along the whole process. I do agree that when we talk about public-private partnership, there are definitely power dynamics, and especially in our part of the world, there are, some issues which we need to look at, particularly in terms of the strength of the private sector to be able to work with government in a way that is mutually beneficial. And I think I made that point during my keynote address. We need to be sensitive about that. And part of the process is to be able to engage them, for them to understand what role they have to play in the whole spectrum of NCD, from prevention to managing persons living with NCDs, and to ensure that it's not a coercive engagement, but more of a partnership, one that is potentially beneficial to both of them. So I think that what we have been doing previously and what we are doing or intend to do moving forward is to continuously engage private sector, looking at what options there are available for them. So for example, in our national health insurance scheme, I gave that example earlier on, private health facilities are accredited to provide health care. So that is a role that they are playing. It may not be your classic or typical PPP model, but they are able to provide service for non-communicable diseases and other disease conditions as well. And government is able to reimburse them. Indeed, in our reimbursement structure, private facilities actually get a bit more than public facilities in terms of the costs for the services they provide. So this is an example of how to ensure that there isn't that superior-inferior relationship between government and private sector in Ghana. Thank you.
The mic sharing. So that you set me up nicely, actually, for the next question, which I'm going to direct toward the efforts underway in Vietnam. Yen, if you could talk a little bit about both how you've worked to address the multi-sectors that are working in the country, and then how you've practically supported NCD programming within UHC in the country.
Yeah, thank you, Caroline. So Dennis just talked in the perspective of the government point. So I'm from the international organization, so I would like to share about our point on that. So you all know that UHC means all people can access needed services without any difficulty, financial hardship. So in the low and middle income country, for example, like in Vietnam, the program, the NCD program is still quite new programs with very limited resources. And it's really the right time to think more innovatively to engage the multi-sectoral partners involved in the process. And for us, for PATH, we work very intensively with Ministry of Health and also local government to call for the partnership from private sectors, for example, like in the for pharmaceutical company like Novartis Foundations, and now we have a support from the asset accelerators, and also in the implementations we work a lot with social enterprises, pharmacies, and we work with the communities, health volunteers, that we can engage a lot of partners in that process. So it have a lot. So in this afternoon roundtable discussion, Tom Fredden, I'm not sure if he's still here. So he mentioned about two important things. It's a right time for task sharing and task shifting. So it's a very crucial for us, and PATH is very proud to be like catalyst. Yeah, to try to engage many sectors to work together for NCD programs. And we are now working closely with Ministry of Health to promote for establishment of the technical working groups that can allow the different sectors involved in that one, especially for private sectors. Yep. Thank you.
Great, thanks. And let's move to Carmen. So you mentioned actually in your introduction, obviously your title is VP of Sustainable Business Innovation. Curious to hear from you your experience and insights into really both from a Merck perspective and broader Access Accelerated perspective, where where you think the industry is as a whole in terms of moving from philanthropy and even corporate social responsibility to very much shifting to shared values, sustainable programs with social impact.
Great, thank you. I think philanthropy is important, don't get me wrong. There are some things that we, as whether we have foundations or global giving or whatever our programs may be, seed funding can really grow and create, fantastic programs and innovations. So I think that is important, and we continue to do that work, and we need to continue to do some of that work. I think we've learned along the way through doing some of that work that you can't do it by yourself. As we're talking here about universal health coverage, we have to be innovative in our thinking and in our partnerships. And so in the past, we've had some success in partnering with WHO and with other private companies, for example, under our Merck for Mothers program, where we helped catalyze a clinical trial to look at an alternative treatment for postpartum hemorrhage. And we were able to have WHO lead that clinical multi-site trial with 30,000 women participating. And it was truly a success with 2 private companies in WHO and then these academics and investigators all over the world. I think we have to take some of those learnings and bring them forward into the future as we try to. We only have 10 and a half more years until 2030. And how are we going to overcome some of these barriers? I would love for us to think about how we can better integrate our efforts so that we're not duplicating systems, for example. So that when a healthcare worker visits a household for a vaccine delivery, they can also take somebody's blood pressure, talk to them or educate them about diabetes. Think about the whole of the person and the whole of the family, because that is really what we're going to need to do to achieve our goals. I guess I would also talk about, as we go into the future, one big part of UHC also is financing. And so how do we think about doing this? This is not an easy task. At Merck, we have started doing more innovative financing and trying to basically bring the power of the dollar or of the money to social impact bonds and trying to have an impact on the ground while still investing funds and perhaps even creating a return so that we can invest in even more projects. One of them that we've just invested in is called the Team Fund, and they're really looking at medtech and tech for innovation around how to help primary providers work through communication channels to get specialty providers to give them advice and help in trying to serve their patients. So this is just one small example of how we might be able to think differently about financing. And I know there have been a lot of panels here this week on innovative financing mechanisms, but this is an important discussion to be had. But also to be listening to our patients about what some of the needs and what some of the gaps are. And I think also one last thing I'll just sort of end with is we talk about government-led, and that is critical in any kind of progress that we're going to make. I want us really to also think about multi-level government. I had the pleasure of meeting with the mayor of Freetown, if any of you have encountered here in New York. And she was talking about what they're doing at the very, very local level in her town and how she's brought together all the sectors around the table. I think it was like 12 different sectors, and basically said to them, this is my strategy. This is my vision. I need you to help me accomplish these goals. And if you can't help me do that, then you can go. And I think we need to encourage leadership like that to help lead us so that we can plug in where those needs are and we can make progress towards this daunting challenge.
Thanks, Carmen. I think one of the things you'll see as you hear from the different companies that participate in Access Accelerated is we've each taken a slightly different approach to our contributions individually. And I think that's great because I think it allows us to lean into what we do well and to learn from each other. And so I'm really thrilled you brought up the financing component. And I think it's a nice segue into Pangasile, who's going to talk about BMS's work. And one of the things I want to note about BMS is, and this is before I joined the industry, really state-of-the-art work in HIV. And I mean, it's really such a proud legacy I think you have in the work that you've done there. And I know that has informed everything you've taken forward in all of your work, whether it be philanthropic or through some of your company access programs. So in that way, if you want to frame it as your call to action, and by the way, this is a warning to all panel members to get your call to action ready. Pangasile, can you start us off with just reflecting on the work that you've done in HIV and then how that's informing the way you think about how we're going to rally all these sectors in the context of NCDs?
Okay. So thank you very much, Caroline, for that introduction. I think we all know that HIV taught us a lot of things. It first of all got everybody mobilized. It was just something you couldn't ignore. However, in responding to the needs there, we also made a few mistakes, which I would like to say we shouldn't be making as we look into NCDs. We just focused on HIV. And everything that we did, which touched on universal access for people living with HIV. So we actually have the experiences, we have done it. But unfortunately, we did it just for one disease. However, there were great investments that were made, and now we need to actually see how we can utilize those investments and bring in NCDs. So at Bristol Myers Squibb Foundation, as it has been said, we did a lot of work, I think since 1999 on HIV, but very soon, as early as 2007, we realized that we needed to start bringing information about cervical cancer screening to women living with HIV. So we brought that on board. And while we were doing that, we figured, while you've got the woman there and you are busy looking at the private or very important parts, you actually needed to talk about breast cancer. So while you've got the woman there, this is a woman living with HIV who will show up at your clinic regularly as you have instructed as a healthcare provider or as a community health worker. So while you have her there, then at least screen for cervical cancer. And while you're talking about that, teach her about breast cancer. So those are just the very simple things that we started doing early on in 2007 in a very, very small way. Later on, of course, it then became a movement that became important. Then we also focused on pediatric HIV, and I'm actually keen to know that as we talk about some of those entities that affect children, are we really seeing them as children, or are we just seeing them as an add-on that we can deal with once we've dealt with the area at for adults? We then looked after the pediatric HIV patients, but now we are using all of that infrastructure and the same model and the same governance mechanisms we had with the government to bring a program that is focusing on childhood cancers, because we have got the pediatricians there, we have got the patients there. So we are now retraining them, and we are bringing the oncologists and those that have got the skills to utilize the infrastructure that we have there and to utilize the mechanisms of getting the information to the children as it's necessary. We have actually saved a lot of lives through the pediatric AIDS program, but now they are adolescents. And what we are now doing in some of our programs is to basically start to advocate for HPV vaccinations. For those adolescents that we save them as children, we can't afford to lose them now. Then there is an issue of TB. We know HIV, TB, and we worked with WHO, and we're very happy about that, because when we worked with WHO, we said, okay, so you've got TB programs, and we've done some work there, but what else? What else? Can we add just a little layer, just a little bit in training, as my colleague has said, to say, can you look at chronic lung conditions? However, we also have got a very big program on lung cancer. And I was asking all the oncologists, and they were telling me that we actually don't have that problem. So I asked them, where do you think your lung cancer patients are? And guess where they were? They were in the TB programs. The first that we found, they just went across to the TB programs and started reviewing those records and started talking to the national TB programs, and then getting those people that were actually query on that side into the screening programs, into the education programs. So those, and that relationship has started. And as we look at the lung cancer issues, it is also informing and improving and assisting the TB program. And we are now saying, can we just talk to those dots whom we have, cadres and cadres out there, millions that we've already educated over years about TB. Can we just ask them to ask a couple more questions? Can we get the primary healthcare nurses who man our clinics to just ask a couple more questions when they are looking at or educating about TB? So I think I can stop there. I mean, we've done the same thing in India for viral hepatitis, where we've got programs on viral hepatitis, and then we went to schools and we said, if you're teaching about viral hepatitis, it's very difficult in schools, but if you make it collective and you start teaching about other NCD risk factors, probably you will be able to catch the children and they will take the message home.
Great. So I'm going to take away your call to action as two things, which is one, to think about actually that patient, which I know we all do, front and center of what they need, because they're not going to present and just say, I need this, you know, to think of them holistically and servicing them that way. And then what I also love about you as an organization is that you're always learning and learning from your previous work, and as industry, we must commit to that, but I believe all sectors should. So thank you for that. Now, I don't want to force any of our panelists to do a call to action, but if you have a call to action or you would like to add on to this conversation, I'd welcome any or all of you. And Pangasila, you can also refine my, my summary. Yes, go.
For me, just to add on what Luisa has said, I believe HIV came with its own pros and cons, and health systems, they got to have a shift on which direction to take. And for the call to action, just to dive it in, we have a private-public partnership with Ministry of Health, Ministry of Agriculture, and just to talk about Ministry of Education, we would want to see the curriculum just have an addition on what we are trying to deal with right now. Have the children and even people in high school, kids in high school, to learn more about ways of just preventing NCDs. And then after that, you know, that will have the public, starting at a younger age, just be aware on a healthy lifestyle and just to promote healthy living. And to touch on Ministry of Agriculture, what we would also want to see as a call to action is to just take extra caution on how we grow our food, how we manage our systems in terms of food delivery as well. And also on the Ministry of those Education, Agriculture, and Health, for the caregivers. Recently in our country, we had the census where we are counting everyone in the country. One person simply asked a simple question. From all these questions you've asked us, no one has been asked, how is your health status? Which was a realization that that should have been considered. So also involve people as well in certain activities. And for Ministry of Health, the caregivers, they need to ask more questions, and that is something that has been mentioned by two parties here on the panel list. And that's it for me.
You want it?
Well, I think for me, the key thing is about the health system itself and its ability to be able to meet the challenges. I mentioned in my presentation that one of the biggest challenges in our part of the world to UHC will be non-communicable diseases. And I make this point because if you talk about even the most basic of NCDs, so high blood pressure and diabetes, in terms of diagnostics, because if you remember, my definition was talking about how complicated it is, but at least for high blood pressure, it's quite simple and easier to diagnose. But the truth is, people don't have access to even basic things as a sphygmomanometer to just check their blood pressure. So if we don't have a system that has the ability to be able to make the diagnosis, then we can say all the nice things we want to say about NCDs. It's not going to go anywhere. And I think the point was made about the need for the government to lead the health system. And it's critical. And all others must come on board to help strengthen the health system. Because at the end of the day, a stronger health system is the only way we can guarantee universal health coverage. And once we build on that, then I think the others will fall in place. And one other thing I also want to hammer on is the fact that sometimes systems vary. Whilst challenges or problems may be similar, the context issues might vary. And I know I gave an example recently when I was in Geneva, and I'll give it here as well. So before I traveled to Geneva, and that was my first time, I heard that Geneva is expensive. But I had no idea, I had no clue what the extent of expense it is to be in Geneva. So it's the same feeling. When I did my master's in public health in the UK, and one of the things that shocked me, I got off a bus and I met this young Caucasian guy and he asked me for 10p. Now, for somebody who had lived all my life in Africa, the mindset is that everybody in the developed country has money. So to find somebody living in the UK asking me for money was a culture shock. And I'm sure that there are a lot of us who would not believe that there are people who don't have access to even basic things in developed worlds. So the context issues are critical. And I think that in the same way, when we also move into the developing countries or the low middle income countries with strategies and plans, we need to be able to consider the context specific issues. Otherwise, sometimes we give prescriptions in terms of solutions which will not work because we miss the context. So yes, by all means, let's strengthen the health system, but let's understand that there are context issues which will vary. And I think that these two examples I've given should be food for thought for all of us as we try to help LMICs to develop in terms of managing NCDs. Thank you.
Thanks. So thank you. I'll take this opportunity. I would just say, for me, the call to action is, can we really be serious about health promotion? Because that may be the easiest. We've got the people, we have got the knowledge. We just have to make sure that wherever people gather, we say a few words about what we want to get going. Also, because of the late presentation and problems with diagnosis, can we also pay attention to palliative care? Because at least that's a list that we can do. We're back to HIV days when we were saying people should die at least with dignity. Unfortunately, with some of the NCDs, we need to go back there. Can we make sure that our systems screen everybody that they touch? If you go into that system, let that nurse or anybody just spend a little bit more time on those two, just asking a few questions. Maybe it could have. And then I have a call to action for my brother here. Can you walk over to your TB and HIV people and ask for some of those resources and ask them to help you to solve some of the issues? Thank you.
I don't know if I can top that. I think what I would say, and it's in the similar spirit, is radical collaboration. That would be my call to action. As I sit here listening to everybody, and if I just brought this group of people here together as a collaboration, We could have a government representative and a provider, a foundation, a patient voice, the private sector, whatever you want that to be, whether biopharma or otherwise, civil society, informed by the voice of the patient, we could come together and create what in business we would say an agile team to solve a big problem. And I think we have to challenge ourselves to do this, but on a large scale, and really to think about what a radical collaboration could look like.
Yeah. So I'm the last one in the panelist. So I have like some comments and a call for action. The first things are like you all know the NCD burdens has been rising dramatically, and it causes a lot of like burdens in the morbidity and mortalities, and it's a really the action is to be like we should work together that we can maximize the partnerships and we can mobilize a collective effort to work on the NCDs. You all know like for NCD programs the funding resources is not high, it's very limited and nowhere as other programs like TB, HIVs. So it's very crucial to work together. Today we know that there are a lot of AA members companies here. So we really would like to look forward for your support in the futures that many like innovation technologies and also like the good models can be scaling up in the low and middle income countries. And for us, like we as an international organization, we're working for health equity. So it's really a good chance for us today to talk with you, to share about our passions, our commitment to work together with you, to give hands to NCDs prevention and control.
Great, thank you. So from that I took context is absolutely critical, and without national ownership we're not going to get anywhere in terms of PPPs for NCDs. Thank you for bringing up prevention and health promotion. NCD Alliance has been hitting its head against a brick wall in terms of making sure that UHC doesn't forget the prevention part, although obviously tonight we're focusing more on the care element. And then really, I think leveraging UHC as a catalyst for radical collaboration, for cooperation and for integration with other areas of global health. This is not just about us, the NCD community. This is about how we work beyond our very comfortable silos and that we truly integrate with one another. So I think we're going to come to you, our audience, now for some questions. We are not doing so well on time, so I think we'll have probably enough time for one round of questions, and we'll come back to our panel. And then we'll move to closing remarks from Thomas. So if you could raise your hands, and then when you're given the mic, just introduce yourself and obviously indicate who your question is to. So Jean-Luc.
Steal one of these, but they're turning back on. Jean-Luc.
Thank you very much. In public and private partnership, there's also the private-private partnership, and I think we are very happy to see Accelerated, so many companies collaborating in this partnership. At the World Health Federation, we have realized that as much as we love talking with WHO, Minister of Health, they know about our problems. And if we want to talk about solutions, we need to start talking with the World Bank, with the Minister of Finances. But if we want to finance universal health coverage, that's where it's coming from. And with this in mind, we have launched yesterday at the UN a report commissioned by the Economist Intelligence Unit called Healthy Budget and Healthy People, which looks at the attitude of the Minister of Finances towards a specific aspect, which is taxes of unhealthy commodities. So my question to the panel is, what are your exchanges in building private-public partnerships? Sorry, what is your exchanges with Minister of Finances or with private financial institutions?
Should we take a couple and then come back? Yeah. Let's take a couple more and then we'll come back to the panel.
I'm not sure which.
Thank you. My name is Sarah Benavent from Orbis International, a non-government organization that works in eye healthcare. Thank you to Access Accelerating for putting together this great panel. And as a small organization working in eye healthcare, is a very niche area, we are forced to partner. We do partner with World Diabetes Foundation and other diabetes entities, for instance. But when we talk about NCDs, we also talk about cataracts, for instance. We're speaking about diabetic retinopathy linked to diabetes. And we sometimes find it hard to work with the structures of governments that are very departmental. So this is a question for our colleague from Ghana. In your NCDs department, how do you ensure that there is integration across the different diseases that fall into your area of responsibility?
Great, thank you. Let's take one more.
In the back, do we have?
Lady in the green, yep.
Thank you. My name is Beatrice Katumia. I'm from Amref Enterprises, which is a social impact business. My question is to Dr. Dennis. Do you have any experience that you can share regarding the development of governance frameworks for sustainability of these approaches?
Okay, so I guess the first question was around experiences from the panel in terms of how you're engaging and bringing in your ministries of finance as much as ministries of health. And then, Dennis, you were fortunate with two questions there. One on how you ensure integration within the Ministry of Health and governance frameworks around public-private partnerships for NCDs. But please, other panelists, jump in on both of those too. Who wants to go first?
Maybe I'll just start. Just on the question on ministries of finance, we have done some of that work, engaging with both ministries, multiple ministries, but ministries of health and ministries of finance in particular. We often get commitments from both. I think where we can do some work together and where folks could help us or give us some ideas about how to crack this nut is how to get them to talk to each other. Because we've gotten commitments and even items in budgets, but only 20% of those commitments ever get paid out to the Ministry of Health. So then how can we actually create sustainable programs without that working well at that level? So on a broader policy front, I think we have some work to do. Anybody else want to address that?
Thank you very much. For the Ministry of Finance, I think I mentioned last year that I participated in a meeting in Denmark, which looked at financing for NCDs. And I was privileged to have participated in that meeting with a colleague from Ministry of Finance, and together we submitted a report to our respective agencies. We also, in the revision of our NCD policy and strategy, actually recognized the importance or the role of the Ministry of Finance in ensuring that issues such as taxation and appropriate funding for NCD comes on board. So we will continuously engage the ministry, and it's something that we are doing. I think I'll ride on the advice she gave. There's a saying in Ghana, in our public health circles, that when you hear integration, then it means there's no money. So yes, I mean, in our policy, we actually made the effort. So we highlighted eye health as one of the things in the policy. So even though we didn't single out some or most major NCDs, we actually singled out eye health and mental health. And that is in relation to the point you raised about the fact that sometimes these things are relegated to the background. So it's part of the process to ensure that we don't leave these ones behind. And it's going to be the example you gave, for example, for diabetes. So if people are screened for diabetes in a diabetic clinic, part of the routine things to be done is also to be, conducting regular eye examination to be able to pick any complications related to the eye early enough so we can be able to achieve some success. On the issue of governance framework for sustainability, it's one of the key things, particularly with the experiences we've had with previous programs or projects which achieve so much, but then when the project ends, then all the successes that came with it also ends. So for example, in initiating any new project in NCDs, our focus as a program or as a service is usually to ensure that we don't run parallel structures. So we don't recruit new staff to, for example, if say we want to strengthen data for NCDs, there are existing data officers. And we don't pick one person and say, look, you are going to be managing NCD data. It has to be systemic. So everybody else in that department that is responsible for data works on NCDs in addition to everything else. So that if the person leaves or is not available, it doesn't mean the end. And also, if there's going to be recruitment, for example, then it has to fit into what we'll call, if they are staff, they have to be existing staff, or when they are recruited as staff who will be working and not as project staff. Because as I mentioned, once the project ends, then, and usually the projects also pay better than existing staff, and that's a fact. So that means that once the project ends, these people are likely to also leave. So those are some of the issues we look at in terms of sustainability to deal with the issue of NCDs. Thank you.
Yes, I just share some experience from Vietnam about how to involve the Ministry of Finance. So often MOF, Ministry of Finance, is the most powerful ministries in the countries, and they have many priorities on their tables. And how we can attract them to invest more money for the health issues. So often, we need very strong evidence. We need good practice and lesson learned from other countries to show to them. And they often ask a question about how much does it cost, any a low cost intervention, etc. So often we do much involve them for advocacy work, like consultation meetings, even study tour to other similar context countries. And lastly, if they are very hard to convince them, we need to do more advocacy work with a higher level. For example, to work with the cabinet, the prime minister cabinet or national assemblies in our political side. So it's somehow we sometimes we go direct and sometimes we go around to take some more political will and commitment to support that.
It's fine. You can keep it. Great. I think we have time for maybe 2 more questions, and then we'll go to wrap it up.
Other questions? Did we have one here?
We did it.
Oh, well, the question has been answered.
We finished on time.
Sorry.
Hi, I'm Dr. Boachi. I'm an orthopedic surgeon in Ghana. And we started a program on spinal diseases treatment, which is like the higher end of medical management, with a lot of patients who come in with multiple comorbidities, who therefore cannot undergo surgical treatment for, say, a broken hip or arthritis of the knee. So the issue has been financing. And when a patient comes to us with HIV or AIDS or TB, because that will be part of our preoperative assessment, the patient will be tested for, say, HIV or TB. And then we have to find treatment for this patient. I know that the retroviral medications are available at no charge, and same for the TBs. So this program has enabled the citizens to have treatment for these infectious diseases. What measures can be put in place comparable to the management of these patients with HIV and TB, so that the multitude who are afflicted with non-communicable diseases like you're talking about, like diabetes and hypertension, also receive similar treatment at a heavily discounted rate or even for free. We know there's no free lunch. Somebody has to pay for it. But if it's work for HIV and TB, can the same thing be applied to the non-communicable diseases, which is killing a lot of people? And then on the other issue of screening, I think prevention is always better than cure. We have talked about people not having access. But what about community health workers going into villages with sphygmomanometers and checking BPs and then making the medications available to them? I think instead of waiting for the patients to come to us, we probably should be going to them, because people don't go to the doctor unless they are sick in the areas that we're talking about where this is a disease burden on us. So I think we need to change the paradigm. So first is the funding for free medication, and then the second is access to care, screening to identify those at risk before they become a problem.
So I can start maybe just wearing my hat from Access Accelerated to answer that question, and then ask the panel members, especially my fellow companies, to jump in. So part of Access Accelerated are independent company commitments for products, and we need to make them independent because our companies each have different strategies there. We can't come together on pricing, as most of you all know. So in that spirit, for Pfizer, we have a program that works in sub-Saharan Africa, deeply discounting our chemotherapy agents, which is a partnership with the Clinton Access Initiative, which we're very proud of. Each company, or the majority of companies involved in Access Accelerated, have similar approaches depending on the company. And we can get you more specific detail on that, but I wanted to give you that as an example. And then I'll let my other company reps respond. In addition, on the training component, one thing I did want to mention, one of the things that I think the industry has done well in terms of public-private partnership has been our work in neglected tropical diseases. And one of the things we learned through that work, specifically what we support at Pfizer, which is our trachoma work, is the important role of the community healthcare worker or extension worker, and equipping that worker with as much as they possibly can take with them to do the screening. Sort of in the spirit that we've talked about, people aren't presenting with just an eye problem. They have a number of issues, and if you have that rare opportunity to engage with them, you need to be equipped to do as much as you possibly can to screen and then refer, if at all possible. We also have a number of different programs underway for community healthcare worker training, both using technology and old-fashioned methods, and we're building off of what we've learned through this comprehensive public health strategy that we've supported out of our trachoma work, but has also been done at an industry level.
Sure. I think that there are multiple layers to your question about access to medicines. I think, like my colleagues at Pfizer, Merck has provided various kinds of medicines throughout the years. The longest running public-private partnership in our company is through our Mectizan donation program, where we donate until we're done Mectizan for the elimination of river blindness, for example. We also, in unique partnerships, we work, for example, with our access program related to reproductive health products. There has been a partnership with the Gates Foundation to help ensure a quantity sort of guarantee that this many products would be sold if we were to lower the price and make access pricing available for some developing countries. And in doing so, then we were able to make that commitment in terms of production, and we call it the Implanon Access Program. But we met the goals in terms of how much we thought we could sell in 2 years less time than what our initial target had been, because that program was so successful. So there are things that we can do if we understand what the needs are, and if we have partners who can help us work out those logistics. I would say, though, and I don't know if maybe NCD Alliance wants to comment on this, but on the broader issue, I think we do need to look at how funding commitments are made in silos and disease-specific wise, and really, come together in a broader community to advocate for maybe more less siloed funding. I'm not sure what the most articulate way to put it is, but I think to answer some of these questions where people come in with multiple disorder or multiple needs, and how do we address that? Because some of these programs are prevented from actually, sharing those funds or supporting other diseases other than those they have been appropriated for.
That might be our hook to say it's time to end. But we can't do that quite yet, although they may force us. Thomas, would you like to join us on stage to just draw this to a close?
Thank you very much. I must say, Dennis was talking about a culture shock when he went to London. I have to admit, I occasionally am confronted with culture shocks when I come to the US. I love New York, but I think it's freezing cold in here. Therefore, the culture shock to Europeans is, oh my God, how can you think that 18 degrees or less is comfortable? Second culture shock to me is, I used to be a member of the All England Lawn Tennis Writers Association, and I once in my life went to Flushing Meadows. Oh my God, the noise level here is quite different from what it was in England, and that's what I thought about now. I also, of course, I hope many of you participated in Walk the Talk on Sunday, because I do believe that when I look at the UHC declaration yesterday, it is worth reading, and it's actually, I'm a former multilateral diplomat, and most of the resolutions which get out of these high-level meetings are not really worth the paper. Now, this actually is quite substantive, and it has a lot of good elements in it, but only if we walk the talk. And I think when I listen to the panel discussions today, SDG 17, which is about partnership, is one where often the talk is more frequent than the walk. And I occasionally tease my colleagues and friends from WHO that FENSA to me looks often like not a framework for engagement, but a wall of concrete built by Tadao Ando. That's why I was really pleased to listen to Svetlana, and I know that the Global Coordination Mechanism and her colleagues, they're really serious about engaging with us, and I think many people are keen to make partnerships work. That's why when I look at how we in Access Accelerate operate, I think one of the important elements and learnings, for instance, from 20 years ago in the HIV/AIDS discussions, and Jeff Sturgeon taught me that, is initially this was classic top-down. You flew in by helicopters or jets, and you knew what needed to be done. I think when I look at how we operate in the countries, there's a lot of listening to people like Dennis or Joseph Kibacho, like you in Vietnam, and I think that's the strength of it. One of the elements also is about the partnerships, because as Caroline and Carmen and you mentioned, each and every company, I think, can be proud of their company programs. But what's new is that companies have come together, try to address the duplication problems, try to talk about system problems, and we haven't mentioned today, one other project, which is our involvement with the City Cancer Challenge. And I'd like to mention it, looking at Sanchia, the chair of the board of the City Cancer Challenge, and Sue Henschel. There too, what I liked most in the original approach of the City Cancer Challenge is it was the cities seizing the initiative and the cities submitting their candidature to become a learning city and now a challenge city. And I think the unique nature is that learning and teaming up, you can scale up things. We in the industry, I think we are often challenged in terms of affordability. And with all due respect, and Carmen, you mentioned the importance of philanthropy. And we will continue to have many elements where philanthropy does play a part. But the difference, of course, we made a lot of progress over the last 15 years in immunization, thanks to Gavi, in communicable disease, not least thanks to the Global Fund. We will not have a global fund for NCDs. Therefore, I think we are challenged, and I mentioned first the industry, to scale up our efforts and not just look at pilots in terms of discounting, making our medicines affordable, but really express our willingness to scale it up and find ways and means to partner to make also our innovative medicines more affordable and not just talk about, you know, our mature products. And that's a challenge to us. That will only be possible, and when you look at the asks of UHC 2030, if one invests more and invests better. I do accept the responsibility that we in the industry have to do more and leave our comfort zones. But I also unashamedly say many others also have to do more. For example, the UHC element, which for me, the one letter which is most important is there, is the U, the universal. It's the no one left behind. And for me, my culture shock when I visited Accra first time was, I asked my colleagues from our companies, what's UHC in Ghana? I knew it covered about 50% of the population, and I asked them, who among you is part of, the Ghana UHC? And they looked in, this ignorant coming from Geneva. Of course, none of us is part of the universal health coverage because we have the money. We don't have to ask for 10p. We have our own private insurance, and therefore me coming from Switzerland, where I'm part of a UHC, where I do pay into the system, and some people pay in more than others, I thought that's an important element, that we also have this notion of the social contract solidarity. I also believe that an important element which goes to walk the talk is domestic resource mobilization. I was yesterday at an event hosted by Nikkei and the government of Japan. And when you look at the beginning of universal health coverage in Japan back in 1961, it was to address the devastating impact of tuberculosis, which was the leading cause of death in Japan at that time. And therefore, you really need the political will. And political will is more than going to the UN, descending on, on New York and causing a lot of traffic jams, because actually walking the streets of New York is much healthier than going by taxi or by car. But it is the political will to make it work. And I listened to Dr. Francis Obasma from Uganda, who actually said, and that's where the patient centricity comes in, people actually need to have a vote. People need to be asked and have a say. I can tell you in my country, one of the most dangerous jobs in politics is be the health minister of a canton, because if you do not respond to the wishes of citizens, you may lose your job. And therefore, the responsiveness is something which is important. I think in Access Accelerated over the last 2.5 years, we can be quite proud of what we achieved so far, but we also need to be humble, and we need to admit this is just the start. We want to work with you as the partners. We want to work with the World Bank, one of our major partners, with the City Cancer Challenge, with the NCD Alliance, the World Heart Federation, and others. I'm really hopeful that over the next maybe 12 to 18 months, we can partner with WHO in this respect too, and we have had some encouraging discussions with Dr. Tedros and many of your leadership team. But unless we manage to really make this FENSA a framework for engagement and not the tada under wall of concrete, we will be stuck in our respective zones. We also need to address UHC in terms of political will. For me, I was mentioning to my friend Amadou Diarra this afternoon, have you read Bottle of Lies? If you haven't heard about it, Google. It is about quality medicines. It is about access to quality medicines, and it is about the importance of high-quality regulatory systems. It is about making no compromise. I was in Kigali earlier this year at the AMREF Healthcare Summit, and one person from Africa whom I respect a lot, he asked me, but Thomas, for God's sake, you can't expect our local manufacturing to meet your standards. And my response was, there can't be dual standards for patient safety. Whether you buy a Volkswagen or a Mercedes, in terms of safety, there shouldn't be a difference. That's why I think it's really important that we use UHC as an enabler to make sure that people are not impoverished because they have to pay out of pocket, to use it to make progress on regulatory harmonization, for example, in Africa. And we need to work together, and we all need to leave our comfort zones. And I think now you deserve all a drink and to be able to stand up and walk and overcome this freezing cold. Thanks a lot for having joined us here.
Thank you. Can you take a quick picture all together? Do you know?
And I would just like to thank our panel members. Thank you for being with us.
Thank you. Yeah.
It's cold. It is cold. And you don't.